So I wanted to continue with some of the potential ways that I think are going to be used to round up Americans that are in disagreement with the political norms of the current political clique, okay? So, schizoaffective disorder, now what you have to understand, this is what's funny with this. I'm not saying that people don't have these symptoms. What I'm saying is that the causes of these symptoms are multifaceted, and clearly how they're being treated isn't working. How do I know it's not working? We wouldn't have an epidemic of so-called mental illness if it was working. This isn't something like cancer where we're getting better imaging resources or things of that nature that allow us to detect cancer earlier or things of that nature. Mental illness, the research that we have with mental illness is proving more and more and more that it's more and more and more a product of the imagination of the people that are inventing the mental illnesses. They are voted into existence. These are not real conditions. These are clusters of symptoms, and what causes the symptoms is not actually known, and probably there are many things that cause these symptoms, okay? But what is most disturbing, for example, my former therapist is a researcher, okay? She is a researcher. So the form of therapy she was using on me was EMDR, okay? So part of that is you got to write down your SUDs, subjective something or other. And I thought it was comical, and she explained to me that everything is subjective. This is a researcher that does sociological research for a university stating everything is subjective. Well, if everything's subjective, that defeats the whole purpose of research, because that would mean that research is absolutely worthless because it's completely subjective. But that's not reality. Reality is objective. People are subjective. And that's why we have things like the scientific method, the engineering method, deductive reasoning, things like this nature, to help to lessen, although it doesn't completely remove, but to lessen the bias to a point where we have usable information. Okay? But if you think everything's subjective, that would mean that everything is subjective. Everything could be based on your feelings, you know? But that's not reality, okay? So, schizoaffective disorder is a mental disorder characterized by abnormal thought processes, delusions, and an unstable mood. This diagnosis requires symptoms of both schizophrenia and mood disorder, either bipolar or depression. The main criterion is the presence of psychotic symptoms for at least 2 weeks without any mood symptoms. Okay, so this would mean that the person would switch between, because the thing is, if you have bipolar or depressive episodes, that can also have psychotic episodes. This is why there was research recently done that showed that psychiatry is scientifically meaningless. The diagnoses of psychiatry are absolutely scientifically meaningless. And this is because there's so much overlap of symptoms in the so-called psychiatric disorders or psychiatric illnesses, etc. So the problem being, if there's this much overlap in these symptoms, it shows that these things are not really real. And even if, like, this is the thing, you can't really test, you can't do a reality test on mental illness, in the sense that you can't say for a fact that schizoaffective disorder exists like a cancer exists, or like a virus exists, or like a bacteria exists. And the reason why is because there's nothing to test it against. You can't go get another schizoaffective thing, like you can get a bacteria or a virus or a chunk of cancer. You can't look at it and you can't say, well, this definitely exists. Instead, what you have is you have many schizoaffective individuals with varying symptoms and varying personalities and various causes of those symptoms. So you're basically testing a theory based in someone's imagination against the theory based in somebody else's imagination. So it's not really even a testable thing, and this is one of the problems with the reproducibility crisis in psychology and social sciences. This is why, it's because you're testing theories against what? What are you testing them against? Other theories? There's nothing, it's not like, there's no metric, there's no actual metric. So the symptoms of schizoaffective disorder are hallucinations, delusions, disorganized speech and behavior, inappropriate laughter, depression, and mania. There are 3 forms of schizoaffective disorder because they weren't happy with just one. So there's bipolar or manic type, depressive type, and mixed type. Common symptoms include hallucinations, delusions, disorganized speech and thinking. Auditory hallucinations, or hearing voices, are most common. The onset of symptoms usually begins in adolescence or young adulthood. On a ranking scale of symptom progression relating to the schizoaffective spectrum, so this is like the autism spectrum, and I'm going to get into that in a bit. When you put things on a spectrum, it makes it very easy to say this person is a little bit of this and this person or a lot of bit of that, and we can just slide that up and down the spectrum based on how much medicine we think the person needs or what have you, or how much persecution they think the person needs. So schizoaffective disorder falls between mood disorder and schizophrenia in regards to severity. So it falls between, now this is the stupidest thing ever. So let's put it this way. If somebody has a quote-unquote mood disorder, like depressive disorder, and, offs themselves, that's a severe issue. If somebody has schizophrenia and hears voices and goes to the top of a clock tower and takes out 15 people, that's a severe issue. So saying that one mental health concern is more or less severe than another is idiotic. What you can say is X, Y, and Z symptoms are more likely to produce a worse outcome for the individual. Now that can be measured in a way, but not really, because it's difficult to test the symptoms. But you could say X, Y, and Z psychiatric symptoms, such as hallucinations, etc., have a worse outcome for the individual than does A, B, and C symptoms. But the problem is, the issue you're running into here with saying that this mental health issue is worse than that mental health issue, which is better than that mental health issue, they're all detrimental to the public and to the individual. Okay? So X, Y, and Z symptoms, if they're extreme enough, are just as bad as A, B, and C symptoms. Okay? So this is a ridiculous thing here to say that one mental health issue is worse than another. That's like saying somebody with obsessive issues is better than, it just doesn't make any damn sense. So while diagnosis of schizoaffective disorder is rare, unless apparently you go to Pendle Mental Health, it is considered a common diagnosis among psychiatric disorders. Diagnosis of schizoaffective disorder is based on DSM-5 criteria, which consist principally of the presence of symptoms of schizophrenia, mania, and depression, and the temporal relationships between them. The main current treatment is antipsychotic medication, combination with either or both of mood stabilizers and antidepressants. So again, they're going straight to the pills without knowing what's causing the symptoms. There is growing concern by some researchers that antidepressants may increase psychosis, mania, and long-term mood episode cycling in the disorder. Okay? When there is risk to self or others, usually early treatment hospitalization may be necessary. Psychiatric rehabilitation, psychotherapy, and vocational rehabilitation are very important for recovery. This is true for anyone suffering from anything. This is true for every individual that goes to school. Okay? So like, the thing is, having a vocational rehabilitation, the ability to do something, is important to every single living human being. Okay? Not just people with schizoaffective disorder. Now, does this improve the outcome of schizoaffective disorder? Maybe, but it improves the outcome of everyone. Okay? As a group, people diagnosed with schizoaffective disorder using the DSM-4 and ICD-10 criteria, which have been updated, have a better outcome, but have variable individual psychosocial functional outcomes compared to people with mood disorders. So, what they're saying here is they have a better outcome, meaning they're less likely to harm themselves or others, is my assumption, or they're more likely to get better, but they're less likely to have healthy psychosocial functioning, meaning their mind doesn't work properly. Okay? So, signs and symptoms. Schizoaffective disorder is defined by mood disorder-free psychosis in the context of long-term psychotic and mood disorder. So you have to have psychosis without the presence of mania or depression for a consistent period of time. Psychosis must meet the criteria A for schizophrenia, which may include delusions, hallucinations, disorganized speech and behavior, and negative symptoms. Both delusions and hallucinations are classic symptoms of psychosis. Delusions are, okay, now this is where we're going to get into this later when I talk about some things that are now considered false beliefs that are objectively provable. You can objectively prove these things, but they're considered false beliefs by the academic community. But yet they're objectively provable. You can see them with your own eyes. You can test them. You can hold them. They're real things that are considered not to exist. So beliefs should not be considered delusional, and that's important. Beliefs should not be considered delusional, but they are. Delusional beliefs may or may not reflect mood symptoms. For example, someone experiencing depression may or may not experience delusions of guilt. Hallucinations are disturbances in perception involving any of the five senses. So you can, now this is also what's interesting about this. This is clearly most likely an undiagnosed neurological issue of some kind. Or for all you know, if you're having an issue with tasting things, so that could be caused by tooth decay. But the psychiatrist isn't a dentist. Okay? Mood symptoms are of mania, Hypomania, mixed episode. A mixed episode represents a combination of symptoms of mania and depression, so bipolar. Symptoms of mania include elevated or irritable mood, grandiosity, which is inflated self-esteem, agitated risk-taking, yada, yada, yada. DSM-5, blah, 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 blah. So, causes. As with everything, of course, it's a combination of environmental factors and genetic factors. Duh. Okay, that's where they're getting. It's a combination of environmental and genetic factors. That's true with literally every freaking thing. Okay? So, genetic studies do not support the view that schizophrenia, psychotic mood disorders, and schizoaffective disorder are distinct ideological entities, but rather evidence suggests the existence of common inherited vulnerability. So keep that in mind. There is no evidence that these things are hereditary, but there is a hereditary vulnerability that increases the risk of all of these symptoms. Mood disorders, so you're more likely, the symptomology is more likely in people that have the symptomology in previous generations. However, is that due to a sensitivity of an environmental toxin or something like that? Who knows? Okay, nobody really knows. Okay, that's the problem. Schizophrenic and affective or more blah blah psychosis, but there is no support from genetics for the view that these are distinct disorders. Viewed broadly, then, biological and environmental factors interact with a person's genes in ways which may increase or decrease the risk of developing schizoaffective disorder or anything else. Okay? And you have to remember the symptoms, because like you see here, there's no proof that mood disorders or bipolar disorder or schizoaffective disorder or schizophrenia, there's no evidence that these are different things, just that people with these are more vulnerable. And these are gene clusters, okay? And I guarantee you, if you really look at the statistics, you'll probably find out that there's not really very strong statistical evidence to prove it. Okay, the physiology of people diagnosed with schizoaffective disorder appear to be similar, but not identical to that of those diagnosed with schizophrenia and bipolar disorder. Okay, now, if you remember, this would explain actually why Dr. Abram Hoffer, had such good results with the nutritional therapies he used, known as orthomolecular psychiatry, because you are correcting a biochemical imbalance, whereas psychiatric drugs cause a biochemical imbalance. What Dr. Hoffer was doing with his nutritional therapies was actually correcting a biological imbalance. But the problem with that is that the evidence for any type of chemical imbalance, aside for the adrenochrome theory, does not really hold water. But the adrenochrome theory actually does hold water when actually looked at. Okay? And that can be caused by stress. What is adrenochrome? It's oxidized adrenaline. Okay? Not QAnon crap. The pathophysiology of schizoaffective disorder remains unclear. Studies suggest that dopamine, norepinephrine, and serotonin may be factors. Now, serotonin has already been proven to not have any issue, does not have any up or down or nothing with depression. Ergo, I would almost assume that probably if they really get into the nitty-gritty, they're going to find out that it doesn't mean shit with this either. Okay, researchers believe that the hippocampus is also involved in the progression of schizoaffective disorder. Specifically, psychotic disorders such as schizoaffective disorder have been associated with lower hippocampal volumes. Now, what the problem with that is does somebody with schizophrenia naturally have a low hippocampal volume, or is it being shrank by the medications that the person's put on? That's a question. That's a question that's probably not being answered, because how many unmedicated schizoaffectives do you think are running around that they've done autopsies on? Okay, so diagnosis. Psychosis as a symptom of psychiatric disorder is first and foremost a diagnosis of exclusion. So a new onset episode of psychosis cannot be considered to be a symptom of a psychiatric disorder until other relevant and known medical causes of psychosis are excluded. Do you really think that when you go to a psychiatrist, they're ruling out any medical causes of anything, ever? Or do you think they're just saying, here's some pills, go take them? Because I can tell you from working in the field, they're not ruling anything out, ever. Now, what they might do if they're a responsible psychiatrist is take a blood test to get a baseline of your liver enzymes and stuff like that to make sure they're not going to kill you with the medication they put you on, if they're a responsible psychiatrist. Most of the time that doesn't happen. Although no biological... See, this is the thing. So it's a theory. There are no biological laboratory tests which confirm schizoaffective disorder. Biological tests should be performed to exclude psychosis associated or caused by substance use, medications, toxins, poisons, surgical complications, or other medical illnesses. Now, the problem with that is how many people have schizoaffective disorder and a substance use disorder? More than a couple. So which is it? Moving forward. So what is cycloid psychosis? Okay, this is like... Well, we're going to get into this. Okay, so episodic or cyclical non-affective psychosis with rapid full recovery between episodes does not fit into any clear diagnostic category. Patients exhibiting this pattern, there is no clear diagnostic category, and we're going to see that later in this series of videos. Patients exhibiting this pattern would clinically be assigned to the DSM-5's unspecified psychosis category. Or, now this is the thing, if you were going to be responsible with how you diagnose people, you would have things like depression with X, Y, and Z symptoms, psychosis with X, Y, and Z symptoms. You would not be playing around and pretending like you actually know what any of this shit is without any evidence of it. You are looking at behaviors in a subjective way. That's the problem. So the patient experiences a clear psychotic episode with auditory hallucinations, paranoid delusions, and a mild thought disorder. There are frequently significant sleep disturbances, but no clear mood symptoms, although distress secondary to psychotic content is present and usually presents as anxiety. The illness is quite cyclical, in this case occurring every 1 to 2 years in the late fall or early winter, even at different latitudes. While superficially these individuals' symptoms appear in both bipolar illness and schizophrenia, studies examining biological markers or diagnostic specificity consistently demonstrate that cycloid psychosis is distinct. No, it doesn't. That's what's funny about it, is they're just claiming that. They're just throwing, it's distinct from these other two indistinct things. However, family members of patients with cycloid psychosis are not at an increased risk of severe psychiatric illness, with their risk being similar to that of non-ill comparison subjects. Nevertheless, at least one study suggested that patients diagnosed with cycloid psychosis can be classified in one of two groups, one in which mood symptoms and family history of mood disorders predominate, and the other with a relative paucity of such features. Many psychiatric disorders have waxing and waning courses of illnesses. Okay, so let's see here. So, but only the mood disorders have discrete episodes with apparent full inter-episode recovery. Blah 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 blah. Premenstrual dysphoric disorder. So, for example, seasonal affective disorder and premenstrual dysphoric disorder. So there's recovery, whatever. However, cycloid psychosis is characterized. Now, if you were thinking about this medically, what do you think might be happening here? Well, if it has onset in the winter, maybe these people, if they're eating seasonal foods, and they're not supplementing with certain nutrients or even a multivitamin, maybe they're not getting enough of certain nutrients present in fruits and vegetables that are not as available in the winter months. Or maybe they just don't like the ones that are available in the winter months, like cabbage and whatnot. Okay? Could be it. Just saying. I'm not a genius, but I think that should be looked into. An acute psychosis not related to drug use. So these are some of the things. An acute psychosis not related to drug use or brain injury with onset between ages 15 and 50. Now, without a brain scan, they don't know what's causing that psychosis. Do you think they're doing brain scans? The condition has a sudden onset with a rapid change from baseline to full-blown psychosis within a few hours or a few days. At least few of the following must be present. Confusion to some degree, mostly expressed as perplexity and puzzlement, mood incongruent delusions of any kind, mostly with a persecutory content, hallucinatory experiences. Now, do you see how this could easily be used to scoop somebody up off the street or scoop somebody up out of their home? Maybe somebody doesn't like their Uncle Ted not giving them the inheritance and they just want to have them found mentally incompetent. Maybe. Okay? And this was the point of deinstitutionalization, was to stop this bullshit. Okay? But do you see how such a vague thing like this, mood incongruent delusions of any kind, mostly with a persecutory content, hallucinatory experiences of any kind, often related to death, an overwhelming, frightening experience of anxiety, not bound to particular situations or circumstances, pananxiety, deep feelings of happiness or ecstasy, most often with a religious coloring or deeper feeling, motility disturbances of an akinetic and hyper, meaning you're not moving around a lot and you're moving around a lot. Okay? So, a particular concern with death, mood swings in the background, and so pronounced as to justify a diagnosis of affective disorder. There is no fixed combination of symptoms, and the symptoms may change frequently during an episode and show bipolar characteristics. Sounds like they have no idea what the fuck they're talking about when you really dissect this thing, does it? So, this is the epidemiology. You can read this on your own. I just wanted to show you what the symptoms are. Maybe you should ask yourself, how many of these symptoms do I have? Maybe you should ask yourself, how many of these symptoms does everyone have? Moving forward. So this is about non-adherence, treatment non-adherence, an epidemic hidden in plain sight. This is from the Psychiatric Times. So, factors that affect treatment adherence, patient-related, younger patients, minorities, patients from low socioeconomic groups, and unmarried patients are less likely to be treatment adherent. Lack of insight and knowledge about the illness decrease adherence. I would say understanding the illness, what this is the more highly educated, which means highly indoctrinated an individual is, generally speaking, the less likely they are to question professionals. Okay, despite the fact that the professional might have zero idea what the hell they're talking about. Okay, and they're saying lack of insight and knowledge about lack of insight or knowledge decreases treatment adherence. Yeah, whose fault is that? Is that the patient's fault? Or is that the psychiatrist's fault for not giving insight or knowledge into the illness? Okay? So, physician-related, good therapeutic alliance significantly increases adherence, complexity of medication regime, and adverse effects have significant negative effect on adherence. So, yeah. If you have a crazy amount of medication that you're taking every day at different times during the day, maybe you're taking medication 4 times a day or some crap like that because you can't it makes it difficult to follow the medication regime. But how come they're not talking about talk therapy? You know what I've never seen? How come you never see physical therapy? We know exercise is great for depression and other mental illnesses and self-image and all this jazz. Why are psychiatrists not prescribing physical therapy, which we know is effective against mental health disorders? Okay? System related. Transportation to get to an appointment, medication, co-payment, availability of follow-up, and duration of the appointment. Social, stigma about mental health issues, negative attitudes, low expectation, disease-related, yada, yada, yada. Okay, examples of adherence interventions. Education, change illness beliefs, psychoeducation about illness and medication. So, this is about brainwashing the patient into thinking that you know what the hell you're talking about. Okay, memory aids, such as pill boxes and blister packs. Behavior. Now, I would say this is a wonderful idea for anybody on vitamins, supplements, or anything. Okay? Medication regime. Elimination of unnecessary medications. Shouldn't there be no unnecessary medications prescribed to a person anyway? Just saying, why would the person be on unnecessary medications in the first place? Physician access to pharmacy, fill data, accurate medication, reconciliation, frequent and regular appointment case management. Financial lowering, elimination of pharmacy co-payments, blah, 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 blah. But the thing is, they're literally saying that not doing what you're told is a mental illness. It's an epidemic, in fact. See? Treatment non-adherence, an epidemic hidden in plain sight. Maybe people don't like the idea of being doped out of their gourd. You ever try and work a 12-hour shift while on antidepressants or some other psychiatric medication? I have. It's not fun. It's like working on weed or being drunk or something of that nature. It is not a pleasant experience, particularly if you work in a field that's dangerous. So some of these medications, if you're working and you're on some of these medications, the medication makes you a danger to yourself and those around you because you're intoxicated. Okay, so we're going to move forward. So what's autism spectrum disorder? Okay. Specialty psychiatry, clinical psychiatry, pediatrics, occupational medicine. Symptoms, difficulty in social interaction. Now, this is the thing. I want you to ask yourself, how many of you have these issues, and how many of the people around you have these issues? Difficulty in social interaction, verbal and nonverbal communication, and presence of repetitive behavior or restricted interests. Complications: social isolation, educational and employment problems, anxiety, stress, bullying, depression, self-harm. So, how many of you suffer from any of these complications in your daily life? Social isolation, education and employment problems, anxiety, stress, bullying, depression, and self-harm. Now, that's the thing. You get what I'm saying with this? Risk factors, family history, certain genetic conditions, having older parents, blah, 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 blah. Diagnostic method based on a combination of clinical observation and development and comprehensive testing. Now, this is one of the things that I will say with this. The thing with autism is this is somewhat like mental deficiency or intellectual deficiency. And the fact that there are tests in reality. So some of the psychometric testing, such as an IQ test, for example, or a memory test, or things of that nature. These are real things that take place in space and time that you can actually measure. Okay? So some of these, so do these people sometimes have symptoms? Yes. But what you'll see is this whole spectrum thing makes it so really anybody can be on this spectrum. In fact, everyone is on the spectrum because you're on a spectrum from 0 to whatever, you know what I mean? Either you don't have it or you do have it, but you're still on that spectrum because it's a spectrum. So applied behavioral analysis, cognitive behavioral therapy, occupational therapy, psychotropic medication, speech-language pathology. So there are many theories about what causes autism. It is highly hereditable and many genetic, but many genes are involved, and mainly genetic, but many genes are involved in environmental. Well, the thing is, though, this is the problem. The classification is the problem. People with autism really do have issues, okay? But do they have issues, like for example, I worked with a person that was mentally challenged and autistic. Now, are there problems coming from the fact that they're mentally challenged or that they're autistic? Not from that they're autistic, okay? So before DSM-5, diagnostic manuals were adopted. What is now called ASD, or Autism Spectrum Disorder, was found under the diagnostic category of pervasive developmental disorder. The previous system relied on a set of closely related and overlapping diagnoses, such as Asperger's syndrome, Kanner syndrome. This created unclear boundaries between the terms. Yeah, so let's try and not make it clear. The less clear they make it, the easier it is to diagnose people. So keep that in mind. It is now known that autism is a highly variable neurodevelopmental disorder that is generally thought to cover a broad and deep spectrum. So keep this in mind. It covers a broad and deep spectrum, manifesting very differently from one person to another. Sounds to me like a load of bullshit. Some have high support needs, maybe non-speaking, and experience developmental delays. This is more likely with other coexisting diagnoses. Others have relatively low support needs. They may have more typical speech, language, and intellectual skills, but atypical social/conversation skills. Narrowly focused interests and wordy, pedantic communication. they may still require significant support in some areas of their lives. The spectrum model should not be understood as a continuum running from mild to severe, but instead means that autism can present very differently in each individual. Exactly. You can have these symptoms. So literally, it doesn't exist. It's literally you either have this, and this symptom, but this person with the same exact thing might not have that, and that symptom. They might have another this, and this symptom. Okay? So while the DSM and ICD greatly influence each other, there are also differences. For example, Rett syndrome was included in ASD in the Rett syndrome. That's hilarious. People that know me, that worked at Pendle Mental Health with me, will know why I find Rett syndrome hilarious. If you remember Rett. So, Rett syndrome was included in ASD. Knowing Rett, I probably would include that person in ASD too. But the ICD-11, it was excluded and placed in the chapter of developmental anomalies. ICD, the World Health Organization's International Classification of Diseases, was released in June 2018, the 11th revision. It describes ASD as follows. Autism spectrum disorder is characterized by persistent deficits in the ability to initiate and sustain reciprocal social interaction and social communication, and by a range of restricted, repetitive, and inflexible patterns of behavior, interests, or activities that are clearly... Now, again, ask yourself, how many of you might have symptoms that could be taken out of context like this? So, repetitive and inflexible patterns of behavior, interests, or activities that are clearly atypical or excessive for the individual's age and sociocultural context. The onset of the disorder occurs during the developmental period, typically in early childhood, but symptoms may not become fully manifest until later when social demands exceed limited capacities. Deficits are sufficiently severe to cause impairment in personal, family, social, educational, occupational, or other important areas of functioning, and are usually a pervasive feature of the individual's functioning, observable in all settings, although they may vary according to social, educational, or other So it's a highly variable thing that blah, blah, blah. It's all over the fucking place. The American Psychiatric Association's Diagnostic and Statistical Manual of Mental Health mental disorders, blah, blah, blah. Okay, is the current 5th edition release. It was the first to define ASD as a single diagnosis, which is still the case. ASD encompasses previous diagnoses, including Asperger's syndrome, childhood disintegrative disorder, PDD, and NOS, post-traumatic, PDD, I got to look up what that is, but that would be not otherwise specified, and the range of diagnoses that include the word autism. Okay? Rather than distinguishing among these diseases, distinguishing among these diagnoses, rather than distinguishing among them, the DSM-5 just says, hey, it's the same thing. Common characteristics. For many autistic people, characteristics first appear during infancy or childhood and follow a steady course without remission. Autistic people may be severely impaired in some respects, but average or even superior in other respects. So, who do you know, including yourself, that may be severely impaired in some respects, but average or superior in other respects? Ask yourself that. So ask yourself, how many of these may or may not apply to you or those around you? Regular difficulties in social interaction or communication, restricted or repetitive behaviors, resistance to change, resistant to changes. Now, I'm going to look at stimming to show you what stimming is, because you might not think that that applies to you until you find out what stimming is. Okay? I know a lot of people that do this. I luckily am not somebody I know that does it, although maybe when I have long hair, I play with my hair, so maybe that's stimming. Who knows? Because their definition is ridiculous. Resistance to changes or restricted interests. These features are typically assessed with the following when appropriate. Problems in obtaining or sustaining employment or education. Difficulties in initiating or sustaining social relationships. Connections with mental health or learning disability services. A history of neurodevelopmental conditions. Common signs of autistic spectrum disorder. Now, the problem with this that I see is these symptoms, again, overlap with so many other things on the DSM, it's ridiculous. Avoidance of eye contact, little or no babbling as an infant. Now, that one is unique to infancy. Not showing interest in indicated objects, delayed language skills, reduced interest in other children or caretakers, possibly with more interest in objects, difficulty playing reciprocal games, hyper or hyposensitivity to or unusual response to. Now ask yourself, do you have any hypo or hyper sensitivity? Do you respond more or less to any of these things? Any sorts of textures, smells, sound, taste, or appearance of things. Resistance to change and routine, repetitive, limited, or otherwise unusual usage of toys, such as lining them up. Okay, repetition of words or phrases like echolalia, repetitive motions or movements, including stimming and self-harming. Broader, now like I said, number one, this crap overlaps with literally everything the hell else in the DSM. Broader autism phenotype. The broader autism phenotype describes people who may not have ASD but do have autistic traits, such as avoiding eye contact and stimming. So even if you don't have enough of these to fit that thing, you might be on the broader autism phenotype. So this is going over the different symptoms in context. So let me show you what stimming is. They might actually say what it is here. Let's see if I hit this. Okay. Self-stimulatory behavior, also known as stimming and self-stimulation, is the repetitive or physical movements, sounds, words, moving objects, or other repetitive behaviors. Such behaviors, also scientifically known as stereotypies, okay, are found to some degree in all people. So it's found in all people to some degree. Those with developmental disabilities are also frequent in people on the autism spectrum. So it's found in everybody, but it's also found in people with autism. Keep that in mind. So social communication skills, and again, ask yourself this. Impairments in social skills present many challenges, yada, yada, yada. Read this on your own. It goes over everything. Okay, so I'm going to move forward here. Oh, actually, this is hilarious. So a variety of characteristics. Some of these include behavioral characteristics, which widely range from slow development of social and learning skills to difficulty creating connections with other people. Autistic people may experience these challenges with forming connections due to anxiety or depression, like social anxiety disorder, or just being shy, which they are more likely to experience and as a result isolate themselves. Other behavioral characteristics include abnormal responses to sensations such as sights, sounds, touch, taste, and smell, So ask yourself, do you have any unusual responses to sights, sounds, touch, taste, and smell? And problems keeping a consistent speech rhythm? Do you ever have a problem keeping a consistent speech rhythm? The later problem influences social skills, leading blah, 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 blah. Repetitive behaviors such as rocking, hand flapping, finger flicking, head banging, or repeating phrases. Sounds like every concert I've been to. Okay. Resistance to change, a strict adherence to routines such as eating certain foods in a specific order or taking the same path to school every day. The person may become distressed. Sounds like OCD. Restricted interests, an excessive interest in a particular activity, topic, or hobby and devoting all their attention to it. For example, young children might completely focus on things that spin and ignore everything else. Older children might try to learn everything about a single topic, such as the weather or sports. And this sounds like interests. It sounds like people with interests in things. Sensory reactivity, an unusual reaction to certain sensory inputs. I mean, this is ridiculous. So, stereotyped behaviors, repetitive movements, compulsive behaviors, time-consuming behaviors include intended to reduce anxiety that an individual feels compelled to perform. Okay, so these are, now, if you know anything about so-called psychology, stereotyped behaviors, repetitive movements such as flapping, head rolling, or body rocking. A lot of people do that when they're anxious, okay, as a means of self-soothing, okay? If you look up zoophobia, you might remember that. Compulsive behaviors, animals do it too is what I'm saying. Compulsive behaviors, time-consuming behaviors intended to reduce anxiety that an individual feels compelled to perform repeatedly, such as hand washing, checking, blah, blah, blah. Ask yourself this. Does that sound like another mental health issue you might know about, like obsessive-compulsive disorder? Sameness, resistance to change, for example, insisting that furniture not be moved or refusing to be interrupted. Oh, wow, that sounds like other shit too. Ritualistic behavior. Wow, that sounds like other shit too. Self-injury, that sounds like other shit too. With restricted interests, that just sounds like you have an interest in something. Okay, each one of these can be taken out of context. Self-injurious behaviors are relatively common in autistic folks and can include head banging, self-cutting, self-biting, hair pulling. Some of these can result in serious injury or death. Higher rates of self-injury are also noted, blah, 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 in socially isolated people with autism. Self-injury could be a response to modulate pain perception. Frequently, yada, 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 yada. An abnormal basal ganglia connectivity may predispose to self-injurious behavior. Okay, I'm going to move on here. Well, you know what? Let's go to exactly what causes the clusterfuck of symptoms that we call autism remains unknown. That's going to take a while to figure that one out with that amount of symptoms. Biological subgroups, syndromic autism and non-syndromic autism. Genetics. Autism has strong genetic basis. Now, what's funny about this? People with Asperger's have, a lot of them have savant-like abilities with mathematics, like numerical reasoning, shit like that. Now, what's funny about that, what else is genetic that we know of? IQ. IQ is genetic. People with Asperger's, which is now autism spectrum disorder, NOS. So IQ is genetic, but people with Asperger's syndrome tend to have average or above average IQs. and tend to be very good with numeric reasoning. Okay, I'm just throwing it out there. Now, does that mean the person is having issues? Being analytically minded can cause very severe anxiety, because when you notice things, it's kind of hard to be in a relaxed state of mind moving forward. So neurodiversity is a proposed framework that argues there is intrinsic diversity in the human brain, function, and cognition, and that certain things currently classified as neurodevelopmental disorders are differences and disabilities, but are not pathological. The framework grew out of the autism rights movement. Now, this is the thing. I would argue that the vast majority of psychiatric symptoms are present in 100% of people. Okay, to some extent or another. Okay? The problem isn't, do these symptoms exist? The problem is what's causing these symptoms to become unmanageable for some people. That's the problem. So, how do we figure that out? Okay? Doesn't seem like psychiatry is the answer. Doesn't seem like the mental health industry is giving any answers. It doesn't. So, I'm going to move on here. So, when we come back, I'm going to go over a video by Ivar Giæver from 2012 regarding what he considers pseudoscience regarding climate change. Now, it's important to note that what he's saying is accurate scientifically, okay? But if you were to take his side of the argument, and I'm not saying who's right here, I'm just saying if you were to take his side of the argument, which is a very well-worded and well-thought-out and provable argument, but if you were to take his side of the argument, you might be deemed mentally ill because you are not agreeing with the status quo.